Mr. Chairman, dear colleagues, it's my pleasure to present today about POT data in the e-ULTIMASTER registry. This registry has been conducted in many countries. As you can see, a total number of 37,000 patients enrolled from October 2014 to June 2018. Just to remind you the situation of POT during this enrollment time, it was initially proposed by Olivier Darmon at EBC 2007. In the fifth consensus at EBC 2009, it was stated that the opinion remains divided as to whether this should be part of the standard approach, and we have to wait until 2016 to get this consensus. But should be considered a standard step in bifurcation treatment. The stent used in this registry was the Ultimaster. As you can see, it's a very well-known platform with specific features regarding the compatibility with bifurcation lesion, regarding the access to side branch, and capability for overexpansion in the proximal part. In this registry, 4,395 patients have been treated on bifurcation. The primary endpoint is target lesion failure at 1 year. All the clinical events have been adjudicated by the independent committee. The rate of clinical follow-up is good. And we here analyze the result by using POT versus no POT and kissing versus no kissing. In order to adjust the baseline characteristics and the lesion characteristics, and also the role of bifurcation technique, we perform a propensity match analysis. Very classical baseline characteristic for this group of patients. As you can see, it was mainly radial access registry, 12% of left main, 2 branches treated in 52%, and 2 branches stented in 24%. True bifurcation is 54%. The technique was, as said, mainly a single stenting. POT was used in 34%. Just to remind you the situation of POT at the time of enrollment in terms of recommendation. And kissing balloon was 36%. When two-stent technique was used, it was mainly T-stenting or tap, followed by crush and culotte. POT is very beneficial, as you can see, no impact on cardiac death, but all other events have been reduced. TVMI, clinically driven TLR or TVR, and consequently the TLF is reduced from 6 to 4%, and there is also an impact on stent thrombosis reduction. If we consider the time domain, you can see that the divergence between these two curves occur very early and still continue along the time to 1 year. You can see that the benefit of POT is very consistent across the different subgroups, considering the location of the bifurcation, the diameters, the technique which is used to prepare or to post-dilate the stent, as well as the presence or absence of DPT at 1 year. When we analyze the predictive factors of 1 year TLF by multivariate logistic regression, we can see that POT is the only one regarding the technical approach, no effect of KBT. All other predictive factors are related to the clinical situation, the age, renal impairment, previous PCI, history of myocardial infarction, and the number of lesions. The story for KBT is a bit different, and we have 2 types of interaction. One is with DPT, meaning when you have DPT at 1 year, absence of KBT is related to a higher risk. And when you have a true bifurcation, the absence of KBT also is related to higher risk. Do we have any synergy between POT and KBT? It's not so clear. We have here a distribution of patients having POT and KBT, POT with no KBT, no POT and KBT on none of them. You can see that we have progressive increase in terms of target LMI on clinically driven TLR. We have significant values for the difference for these 2 points, and also a slight interaction with stent thrombosis. But of course, it's difficult to demonstrate this synergy considering the extremely low rate of events we have in the group of patients having POT and KBT. So to conclude, POT is clearly beneficial in all bifurcation lesions, whatever the stenting technique. KBT is definitely not a substitute for POT. There is no interaction between POT and KBT, but maybe there is a synergy. It's possible, but it's difficult to establish considering the low event rates we observe when we have performed both POT and kissing balloon technique. I thank you for your attention.
Yeah, Chairman, Dr. Lefebvre, thank you very much for the kind invitation to the EBC meeting, and also thank you to TERUMO for sponsoring this session. The presentation title for today will be POT in the bench model with Ultimaster Tansei stent. So my job today will be to illuminate the fact, as we have previously seen, that POT can improve clinical outcomes. Now, the straightforward answer to that would be that POT corrects underexpansion in the proximal segment of the bifurcation. And what I would try to deal with on the bench model is how POT facilitates side branch access, so how it can help procedurally if side branch intervention is needed. First of all, when we talk about POT, it is not only the proximal optimization we talk about, it is a technique. And as any technique, it needs to be learned and executed correctly. So the emphasis of this brief presentation will be on how to correctly execute proximal optimization. And thereby, I would like to focus on two important segments. Not to overlook the proximal edge of the stent, and secondly, how to be precise at the point of the confluence at the bifurcation core. So let us first start with the more proximal segment. If you do not perform POT at all, what is naturally going to be happening, and you see it here on the bench, and thank you to Dr. Lefebvre for performing meticulously this bench testing, what you namely see is that you can rewire abluminally. So you basically go behind the struts and you proceed then into the stent lumen without noticing this on most occasions on the angiography. And that is the great value of this bench testing, because it shows us that not seeing this on angiography has dramatic procedural consequences. So not performing POT leaves you with malapposition and underexpansion, and the malapposition that you have in the very proximal edge of the stent can lead to abluminal rewiring. To avoid this, or to circumvent this, you can perform POT and all is good. However, POT, being a technique, needs to be performed correctly, and if you perform it like this, as you could see on this example, it is too distal. So performing it too distal or with an undersized balloon leaves you at the proximal edge of the stent with the very same result as not performing POT at all. What you see now here on this bench test is that the wire doesn't go straight forward into the stent lumen. It rather still can go behind the struts, and you can still have abluminal rewiring, even though you think that you have performed POT. It was not performed correctly, and it leaves the proximal part of the stent still not expanded well, with a large portion of malapposition. So if you think in terms of graphically depicting what we just saw, on the left-hand side of the slide, you see no POT at all, and on the right-hand side of the slide, you see inadequate POT with too distal and or undersized balloon. The consequence is the same. You can rewire abluminally. Now let us focus on the more distal segment at the bifurcation core. So if you do not perform POT, or if it is performed in a way that is not correct, you will practically always aim for the proximal cell when trying to rewire the side branch, as you can see nicely here in this bench test. This is not what we try to achieve with crossover stenting. We try to go as distal as possible when re-accessing the side branch. So how can we correct this? How can we give us a chance of distal side branch access? Well, by performing proper POT. And as you can see on this bench test, this may require 2 balloon inflations. So we need to take care of the proximal edge of the stent, and we need to be precise at the carina. What you now see after performing optimal POT, the wire still preferably goes through the proximal cell. However, we gave ourselves the chance of rewiring through the distal part, as you can see now. So once again, performing POT requires meticulous proceeding, and it may require more than one inflation. It is just important for us to know what are we doing. We need to be precise at the proximal edge, but we also need to be precise at the distal edge of the bifurcation core, basically. Only then can we allow ourselves the opportunity to have distal side branch access, which is for us important, as you see nicely here on this bench test. So you can always argue, or some colleagues argue, well, if we perform POT too distally, the consequences are Carvina shift, and Carvina shift may go away in a few days. Well, that is not always the case, and you see here in top, if we perform too distal POT as depicted here, what is the consequence? The consequence is unintended crush. You see here the nice near Carvina of correct top, and this is what happens if you do what was just done on the previous slide. This can, of course, translate to stent-related events. In conclusion, proximal optimization requires meticulous technique, and it requires knowledge how to perform POT, not forgetting the proximal edge of the stent and being also precise at the distal part at the bifurcation core. Thank you very much once again.
Dear Chairman, thank you for the kind invitation to present at EBC 2021 and to TERUMO for my involvement in this symposium, Mastering POT with Ultimaster. I've been asked to provide a clinical case discussion. So let's see, a 56-year-old male, in fact a medical colleague, which made decision-making slightly more fraught, presented with non-ST elevation acute coronary syndrome, preserved LV function, was found to have this significant proximal LAD lesion extending back to the left main stem. We see on multiple projections this severe disease within the proximal LAD, and this then leads to a question of whether you would nail the ostium, stent left main to LAD, consider a Lima graft, or image to then decide. And this was a polling that I placed on Twitter prior to presenting this case last year at an Indian symposium. In fact, half of those respondents suggested imaging first, perhaps partly led by the fact that I was asking the question. But we see that, some of the correspondents were suggesting nailing an ostium is unpredictable, that we certainly know that imaging studies help in terms of delineating where disease extends. Going straight to a stent, Peter O'Kane would suggest, is unnecessary, that you have to consider the imaging. Simon Ecclesall suggesting that we should be considering drug-eluting balloon. So I went about imaging without predilatation, so the quality of this run is not perfect, but actually it answers the question that I required, which is that we see disease extending back into the ostium of the left main. So we see the left main is about 4.5 lumenly. We see plaque at the ostium of the LAD. We see plaque at the ostium of the circumflex. And that very much fits with the IVUS consensus led by Gary Mintz, which showed beautifully that despite the Medina classification, that by imaging, we see that 2/3 of cases have disease that affect all three limbs. So I put out a second poll. Now we've imaged, what are we going to do? Well, there actually then was a relative split between nailing the ostium, regardless of the fact that there was disease extending to the distal left main, or stenting left main to LAD. Now, actually, the most contemporary EBC consensus would probably lean towards a crossover stent left main to LAD strategy, which was in fact what I selected. So having pre-dilated now with a 3.0 NC, we get much better appreciation of the burden of disease. I've committed to the left main, so we see extensive injury. And in fact, you see now coming back into the left main that there is actually a relative absence of dissection at the moment extending into the left main stem. But select a 38mm stent which can be 3.5 distally, but is going to need to expand to 4.5 proximally. And it's critically important we select a device that can appropriately expand. Now, the Ultimaster Tansei absolutely has that capacity. It's a very open cell design. It offers very uniform scaffolding, and it purposefully has just an abluminal coating for delivery of the sirolimus drug. And most importantly, as I've already suggested, this 3.5 platform will on bench expand to 5.8, as shown by Nicholas Foyn's group. So I place a 3.5/38 Ultimaster Tansei, placing in multiple projections. I undertake an OCT at this point actually just to accentuate the issue of this pre-POT under expansion of the stent. And we see beautifully here towards the polygon of confluence how massively under expanded that stent is within the left main segment. So it's then important to undertake the POT, and there's always discussion about where to go. And again, this was another polling for the purpose of an educational presentation, which is less easy to do in this virtual world, unfortunately. But I hope you'd all agree that position D is probably preferential in terms of placing it onto the carina, so a distal placement to enhance that apposition and open up the cells to recross into the circumflex. At this point, the OCT is used to confirm a cross of the wire, which actually was quite challenging in this example, and took multiple passes, and I never quite got as distal across as I was hoping to achieve. But ultimately, accepting the passage that I achieved, I undertook a 4.5 by 2.75 kissing inflation to clear the struts across the circumflex, and then went on actually, but due to pinching of the diagonal branch, you can see in that cranial projection, to also kiss into the diagonal, again making use of this Tansei technology, which is advantageous in bifurcation. And ultimately achieved an MSA in the LAD of 7.2 millimeters squared, and in the left main of 16 millimeters squared, that really will offer the patient an excellent long-term outcome. And we see here from distal to proximal, the difference made by the POT and then actually the kissing in terms of the stent coverage and the level of the polygon. So the learning, I think, from this clinical case is that there is controversy actually with a Medina 010 type anatomy. The consensus does lean towards crossover, and I've shown a nice example of where that can be efficacious. POT is absolutely mandated in bifurcation PCI, and I think stent design does play an important part in achieving good results for our patients, alongside the use of guidance by imaging to assure ourselves that we can achieve the best possible result. I thank you for your attention.